Okay, guys, so in this voice note, we're going to be looking at the general exam. Okay, and what we're going to be focusing on is the very basis of the general exam, which is JACCOL, right? So, jaundice, anemia, clubbing, cyanosis, edema, and lymphadenopathy, right? So, we must understand what causes these signs and symptoms, right? And what is the mechanism that produces these signs and symptoms? It's very important for us to understand, because whenever we look at something, we need to ask ourselves, what causes this and how is it caused? We must always ask ourselves these questions, right? So that's how we develop clinical reasoning. The objective of cardinal symptoms of module in third year is to get you guys to develop clinical reasoning. So when you see a sign, you are able to think critically as to what could possibly cause the sign, and in order for you to do that, you must understand the mechanism by which these signs are produced in the body. Right, so just to quickly run through the general procedure when you're doing a general exam, what you do, the first thing you're looking at is this patient conscious, right? And remember, many different things can alter the level of consciousness of the patient, syncope being one. Is the patient cooperative? Orientation of the patient, very important, because it is talking about the patient's mental state, right? What else are we looking at? Is the patient in respiratory or pain distress? Remember that an increased respiratory rate is a predictor of respiratory failure, right? And one of the signs of respiratory distress, use of the accessory muscles of breathing, nasal flaring, tachypnea, grunting in a child. Patient would possibly have cyanosis, depending on how severe the respiratory distress is. And we see use of the accessory muscles. Which muscle are we talking about mainly? Sternocleidomastoid muscle. What about intercostal recession? So recession of the intercostal muscles, also a sign of respiratory distress. Okay, so just go through your signs. Right, so we said we're looking at, is the patient in any respiratory or pain distress, nutritional status of the patient. Remember, is the patient wasted? Because if the patient is wasted, it points to what? A debilitating condition. You could possibly think malignancy. What else are we looking at? If the patient is obese, what would that point to? Many different lifestyle conditions, that hypertension, hypercholesterolemia, ischemic heart disease, which would result from lifestyle disorders and result in cardiac pathologies. So remember, you must think critically, think about the different systems that could be affected by a particular sign, right? Because it's not only CVS. I'm just giving you an example. Right, so, and is the patient comfortable in that position? So once you've gone through that, you will now assess the vital signs. What are our vital signs? The pulse, right? So you're assessing the radial pulse. In the ward, you will assess it for 30 seconds or for a minute. In the OSCE or the clinical OSCE, you do it for 15 seconds because you don't have time, and you multiply it by 4. And remember, you're assessing the rate. Normal rate is 60 to 100. Above 100 is tachycardia. Below 60 is bradycardia. You're assessing the respiratory rate, right? So normal respiratory rate is what? 12 to 20 breaths per minute. More than 20 tachypnea, less than 12 bradypnea. Temperature, right? Normal temperature 36.9 or 37 degrees. And remember, an increase in temperature, increase in temperature can be caused by infectious or non-infectious causes, but generally we look at the most common things like upper respiratory tract infections that could cause organisms that would cause what? An increase in the temperature. What else are we checking? The blood pressure. And remember, when assessing the blood pressure, what are we thinking? Postural hypotension. So you want to assess the blood pressure when the patient is sitting, as well as when the patient is lying down, as well as when he's sitting or standing up, right? Right, and remember, when you are assessing the radial pulse, you assess for radial delay. If there is a delay, you're thinking what? An obstruction. Yes, an obstruction could possibly cause it by an embolus, a thrombus, and also if the patient possibly has an aortic dissection. And then what could cause a radiofemoral delay? Coarctation of the aorta, which is narrowing, right? Right, and basically, what's an aortic dissection? It basically means that you have tearing of the wall of the blood vessel. So you have blood that's now sitting between the 3 layers of the wall. So between the tunica media and tunica adventitia, right? So that's an aortic dissection. We will discuss this more in the CVS discussion, right? So that's basically your general procedure. Now we're going to move on to understanding JACCOL. So the first one is jaundice. Right. What is jaundice? Jaundice is a condition whereby we have yellowing of the skin and you have yellowing of the sclera, right? And what causes it? It is an increase in the bilirubin. So hyperbilirubinemia, an increase in the bilirubin level in the blood. Now, at this point, we need to ask ourselves, what is bilirubin and what could possibly cause it to be increased? So let's think about it. You have a red blood cell and red blood cells have hemoglobin, right? And if you take hemoglobin and we break it down, you're going to get heme and you're going to get globin. And if you look at the heme component only, forget about the globin. The heme component, if it breaks down, you're going to get iron and you're going to get something called biliverdin, right? So this biliverdin can be broken down into bilirubin, right? This is how we're getting the bilirubin from hemoglobin, from the heme component. Now remember, this bilirubin that is in the blood is unconjugated bilirubin circulating in the blood bound to your plasma protein, which is albumin. When this bilirubin now reaches the liver, it gets taken up by the hepatocytes. The albumin gets recycled. And what happens to this unconjugated bilirubin in the liver? The liver conjugates the bilirubin to glucuronic acid. Now, there's a specific enzyme that's very important that is responsible for the conjugation of bilirubin to the glucuronic acid, which is something called uridine diphosphate glucuronoside transferase enzyme, right? This enzyme is responsible for the conjugation of bilirubin. It is important because if there is a deficiency of that enzyme, you're going to have unconjugated hyperbilirubinemia. Okay, so we must understand the process by which this happens. So once we have conjugated bilirubin, what happens to it? It's a very important component of bile. So that means it's going to get excreted way into the duodenum, right? And what happens when it enters into the intestine? The conjugated bilirubin is broken down into what? Into urobilinogen, right? So it's broken down into urobilinogen by a gut flora, and then as it gets broken down further, the urobilinogen becomes stercobilinogen. And it's stercobilinogen that is responsible for giving your stool that brownish color, right? But remember that some of the urobilinogen from the gut can get reabsorbed back into the bloodstream and get excreted via the kidney in the form of urobilin, right? Very little gets reabsorbed. Now that we understand this whole process of bilirubin and what happens, patients that have jaundice, we saying that they have hyperbilirubinemia. So it could be that they have unconjugated or conjugated hyperbilirubinemia, right? And we need to understand the causes. You get prehepatic, hepatic, and posthepatic causes. So what could cause a prehepatic jaundice? If we have increased breakdown of red blood cells, right? Because it means that you're going to have what? Increased heme and increased biliverdin being converted into what? Bilirubin, unconjugated bilirubin. So what would cause it? A hemolytic anemia. So you get different kinds of hemolytic anemias that we'll discuss later on. So hemolytic anemia is a cause of prehepatic jaundice. Why? Because you have increased breakdown of red blood cells, and this is happening before the bilirubin reaches the liver. So it's prehepatic, right? Hepatic cause of hyperbilirubinemia would be hepatocellular failure, because it means that the hepatocytes are no longer functioning, so they cannot conjugate the bilirubin, right? We understand that. So you're going to have hyperbilirubinemia. And a post-hepatic cause of jaundice would be what? Yes, an obstruction, a biliary obstruction, because it means that you're not going to have bilirubin being excreted into the intestine. Right. Now that we understand the different causes of jaundice, we must understand where do we look for jaundice when we're looking for the signs. We look at the skin, yes, the yellowish discoloration of the skin, and we look at the sclera. So we'll ask the patient to look down while we examine the sclera, right? It's a yellowish discoloration of the sclera. So there's two places where we look for jaundice. Now, when we think jaundice, we must think pruritus. Pruritus is itchiness. if the patient has itchiness, what are we looking for? Scratch marks on the body. So when you think jaundice, you think pruritus. And there's one other thing you'll think of is pale stool and dark urine, right? So when you think of jaundice, it's associated with pruritus. It is associated with pale stool and dark urine. We just looked at the whole mechanism of bilirubin, and we said when you have bilirubin being excreted in the intestine, you have stercobilin, and stercobilin is responsible for giving your stool that dark color. So obviously, if there's an obstruction or you're not having the bilirubin being excreted via the intestine, you're not going to have your stool having that brown color. And what does it mean? It means that because bilirubin is an important component of bile, remember that bile is responsible for what? Emulsification of fats. And you're also going to have fats not being broken down, so your stool is going to appear to be white. Right. And dark urine. Why dark urine? Because now you have increased amounts of this bilirubin being excreted via the kidney. So the urine is going to appear to be darker. Because remember we said it's the urobilin that gives the urine the yellow color. So if you have more urobilin in the urine, it's going to be of a darker color. So that is why whenever we talk about jaundice, we say pale stool and dark urine. Right. We looked at this mechanism. I hope this provides some sort of a good explanation of jaundice. The next one is anemia. Anemia is very simple. What causes anemia? Hypoalbuminemia. Another cause of anemia? Shock. Right. The next one we're looking at is cyanosis. Where do you check for peripheral cyanosis? The fingers and the toes. What causes peripheral cyanosis? A reduced cardiac output, which could be due to shock or left ventricular failure. What else? Exposure to cold, or if there's an arterial or a venous obstruction. Okay, when we say shock, what do we mean? That there is a decrease in the cardiac output such that the oxygen demands of our tissues are not being met. That's what it means, right? And remember, with peripheral cyanosis, it means that there is a decreased amount of oxygen in the blood, so the tissues are now drawing more oxygen than normal, and it is creating that bluish discoloration that we see. Right, that's peripheral cyanosis. Now we need to understand what causes a patient to have a central cyanosis. And where do we look for central cyanosis? We look at the tongue, generally tongue and mucous membranes. Right. Now, what causes central cyanosis? Generally, it's a decrease in your arterial oxygen saturation in the lung. What could cause that? If the patient is hyperventilating, right, because they're in a coma or there's an obstruction, or if the patient has a lung disease such as COPD with cor pulmonale, right? What else could possibly cause a patient to have a central cyanosis? Polycythemia. Polycythemia is a condition whereby you've got an increase in the blood cells is to plasma ratio, right? And what else could it be? Hemoglobinopathies. So a variety of hemoglobin pathologies could cause a patient to present with a central cyanosis, because we know that hemoglobin is our oxygen carrying molecule in the body, or protein, right? So that is the causes of central cyanosis. But the first thing you think is decreased arterial oxygen saturation. You're thinking lung pathologies and you're thinking hypoventilation along that line.